Hello, my name is Jamison Schroyer, and today I'd like to talk about autism spectrum disorder in children. This is a brief overview on childhood autism spectrum disorder, or ASD as I will call it from here. Most of the research cited in the slideshow was published within the last 5 years of this presentation, and only one resource was published before the DSM-5. ASD diagnosis and screening. Diagnostic symptoms of ASD. The DSM-5 lists 2 symptomatic domains to diagnose ASD with additional criteria for each domain. The first domain is difficulty with social communication. This can present itself verbally, non-verbally, and through difficulties forming and maintaining relationships. The updated DSM-5 TR mandates that all 3 criteria for social communication be present for a child to be diagnosed with ASD. The second domain, restricted and repetitive behavior, or RRB, can present as repetitive physical motions, need for routine or ritual, fixation on interests that are not typical, and divergent responses to stimuli. You might be familiar with the term stimming, which is a type of RRB. Screening for ASD. Early screening begins at 18 months and again at 24 months. Level 1 and Level 2 screening can typically be done by caregivers. Level 1 screening will assess if a child could be at risk for ASD, while Level 2 screening assesses children already known to be at risk for ASD. Parents can use screeners like MCHAT to assess if they should follow up with their child's primary care provider. MCHAT is a Level 1 screener. The primary care provider will do their own screening, something possibly like a SCQ, Social Communication Questionnaire, which is a Level 2 screener, and then provide a referral for clinical assessment if they confirm risk of ASD. Prevalence of ASD in children. A 2014 study shocked the medical community for reporting that the rate of ASD diagnosis went up more than double within 12 years, with 1 in 59 children being diagnosed. More specifically, 1 out of 59 8-year-olds being diagnosed. Factors for this rise are unknown, but could have to do with newer scientific research and a broader diagnostic definition for ASD as a spectrum. Just a year after, another study reported 1 in 45 8-year-olds had ASD in the US, and most recently, a 2021 study reported that 1 in 44-year-olds had ASD in the US, and actually 1 in 160 8-year-olds had ASD globally. This could imply that the rate of diagnosis has begun to level out. Comorbidity. There is a rate of about 31% of children with ASD having an intellectual disorder, as well as having ASD. While there isn't much research into other comorbidities in children, Avni et al. 2018 did find that about 63% of children with ASD had ADHD as well, and 44% of children with ASD had anxiety disorders. And they even suggest that anxiety could cause some of the RRB that we see in children with ASD. Culture and family. Cultural considerations. Race and ethnicity are not known factors for a child having ASD, though race for ethnicity may affect the probability of earlier diagnosis. Familial acceptance of ASD diagnosis may also be affected, but more on that soon. White children are diagnosed with ASD at higher rates than children of color or other minority status. Children and minorities are also diagnosed later in life than white children. Less access to medical care, education, and other resources because of socioeconomic status may be the culprit for these rates, as opposed to simply race being a reason. Gordillo et al. 2020 interviewed mothers of children with ASD and found that most mothers who immigrated from Latin America did not learn of ASD until arriving to the U.S. Even then, ASD was thought of as a U.S.-only disorder that didn't exist in their countries. Rates of acceptance of an ASD diagnosis for their children was less in Latin American migrant mothers. Benavides et al. 2019 found that Hispanic families are much more likely to spend personal time providing child care for their children with ASD. They also found that white families spend more money annually on child care for children with ASD. In this study, they do elaborate that this is not a study based on socioeconomic status. There are plenty of cultural and environmental factors that can contribute to the results of their findings. Impact on the family. There are higher rates of depression and stress in families of children with ASD. This includes families of children with other developmental disorders. So families show higher rates of depression and stress with children with ASD more than if the child had a different developmental disability. In addition, families with children with ASD overall generate 28% less income and will pay more for healthcare, education, and resources and services that are specific to ASD. Emerging evidence-based practices include or require the caregiver to learn interventions for children with ASD. This hands-on approach requires more time and attention from the parents. A quick mention here are a couple resources found online for parents. Alaska Infant Learning Program can be found on the Alaska Health Department page on the Alaska State website. Provides screening and resources that can connect parents to pediatric care providers and other resources. Stone Soup Group works with children of many disabilities and offers classes, community, and other resources specific to ASD. Evidence-based practices. Discrete trial training, or DTT, is the most researched and requested intervention for ASD and is the most common, according to Prinstein et al. 2019. During DTT, the instructor conducts many small trials throughout the session that teach small skills in children with ASD to improve broader, more complex skills. DTT is popular and has been proven to be effective. However, it's highly structured and does not allow for much adaptation to the individual client. DTT may not be the best approach for toddlers who may benefit more from a more naturalized approach, but I will get to that one next. According to Thompson et al. 2009, each discrete trial is about 5 to 20 seconds and are all formatted with the following components. First, an antecedent cue or discriminative stimulus is proposed to the child, such as verbal instruction. If the child is not responding to the cue, the clinician may prompt the child. This could mean guiding the child's hand. Prinstein et al. 2019 also proposes modeling to prompt the child, such as the clinician performing the desired reaction, and that would be opposed to them grabbing the child's hand and guiding it. They would just perform out themselves doing the task. The next step is waiting for the child's response, and then the clinician delivers a consequence based on the response. The consequence for the child performing the desired response is positive reinforcement, like receiving a piece of candy. Whether the child performs the desired response or not, you move on to the next discrete trial. Naturalistic Developmental Behavioral Intervention, also known as NDBI, differs from DTT in that it is conducted in a naturalized environment where the child leads the play and the adult follows the child and engages in interventions as they arise. According to Morocco et al., 2023, adults should play with a child when it's appropriate, employ interventions such as imitation, making comments, and also setting up an environment that engages the child and will promote intervention and reinforcement from the adult. Very similar to DTT, only it's more in an environment that's comfortable to the child leads it, so that makes it more naturalized rather than a more structured, manufactured environment that the child is placed into. And that's why NDBI is a new and emerging evidence-based practice. Here are my references. Thank you for taking time to watch my presentation. I hope I was able to provide you with something new that you hadn't known before on autism spectrum disorder in children.